Good morning, everyone. Today I'm going to present on the topic approach to bone tumors in radiology. So today we'll learn how to describe a bone tumor on an X-ray. We learn how to form a differential diagnosis for a given bone tumor, and then we'll also discuss some example cases. So first of all, how to describe a bone tumor. So whenever we are seeing any X-ray of any bone tumor, first of all, note the age of the patient because it is very important. Different bone tumors have propensity to occur in different age groups. For example, metastasis and myeloma, they generally occur more than 40 years of age. And benign bone tumors are more common in less than 30 years of age. Then we have to look at the location, that in which bone the tumor is located, whether the tumor is in a tubular bone such as humerus, femur, tibia, or it is in a flat bone, for example sternum, ribs, pelvis, sacrum, so patella. So these are all considered as flat or small bones. uh, then we have to note where the tumor is located with the bone, the site within the bone. If it is a tubular bone, we have to note whether the lesion is in the metaphysis, in the diaphysis, or the epiphysis. The lesion may involve more than one, and it may be epimetaphyseal, diametaphyseal, and we also have to note whether the lesion is central or eccentric. Similarly, if a tumor is in the spine, then we have to note whether the tumor is involving the body of the spine or the neural arch of the vertebra. Then one very important thing to note is the zone of transition. Zone of transition means how well demarcated the tumor is, whether we can differentiate the lesion and the normal bone. Like for this is a narrow zone of transition. We can easily see the margin of the tumor, and this one, this has a wide zone of transition. We cannot easily make out the difference between where the tumor lesion ends and where the normal bone is. A narrow zone of transition is associated with a benign tumor on X-ray, whereas a wide zone of transition is associated with a malignant tumor on X-ray. The zone of transition is more important in X-ray and not that important in MRI. Then we have to describe the matrix of the lesion. What is inside this lesion? Whether it is lytic or there is some calcification. If there is calcification, the calcification, it could either be like mature bone calcification, which is called as osteoid matrix, or it could be in the form of stippled calcification in the form of rings and arcs, which is called as chondroid matrix, or there can be a diffuse haziness inside the matrix, which is called as ground glass matrix. Osteoid matrix is typical of osteosarcoma. Chondroid matrix is seen in any cartilaginous tumor such as enchondromas and chondrosarcomas, and ground glass matrix is seen in fibrous dysplasia. We also have to note if there are any trabeculations inside, because trabeculations inside the bone gives rise to soap bubble appearance, which is classic of giant cell tumor, but it can also be seen in many other tumors also. Or if we are seeing the MRI, then we must also note the T1 and T2 signal of the lesion, because we know that if a tumor is both hyperintense on T1 and T2, it indicates that it contains fat. Whereas if a tumor is both hypointense, it is hypointense on T1 also, as well as hypointense on T2, it signifies that that tumor may be containing some fibrous tissue. We must, if we are seeing an MRI, then we can also note whether the tumor contains fat, or if the tumor is cystic, or if there are blood fluid levels inside the lesion. We must also note if there is any periosteal reaction. Periosteal reaction means formation of bones within the periosteum. So if periosteal reaction can either be, there can be no periosteal reaction, or there can be a smooth periosteal reaction. Now, no periosteal reaction or a smooth periosteal reaction is generally indicative of a benign tumor. However, some benign tumors, such as aggressive benign tumors, such as osteoid osteomas and eosinophilic granulomas and infections, they can also give rise to sometimes a smooth type of periosteal reaction, and sometimes infections, very aggressive infections, can also give rise to an aggressive variant of periosteal reaction. And some malignant tumors, on the other hand, such as metastasis and myeloma, they're generally small and very well defined, and they do not generally produce any periosteal reaction unless they get fractured. Whereas aggressive periosteal reactions include lamellated periosteal reaction, in which onion peel appearance of periosteum can be seen, and sunburst periosteal reaction, in which typically spiculated periosteal reaction is there, and Codman triangle, in which the periosteum gets lifted up by the tumor. Now, the lamellated, sunburst, and Codman triangle of types of periosteal reaction are generally seen in malignant tumors. However, sometimes a very aggressive infections, they can also produce sunburst type of periosteal reactions. So there can be sometimes overlap, but overall it gives help to narrow down the diagnosis. Then we have to note the cortex of the tumor. A cortex can either be intact or a cortex may be broken. A broken cortex without any history of trauma indicates that this tumor is malignant. And remember that there is a difference between broken cortex without trauma and a fractured bone. Now, fracture of the bone leading to cortical break can occur through any lesion. It may be benign or it may be malignant, and that fracture is called as pathological fracture. But if you get history of a broken cortex without any trauma, then that uh, lesion is definitely malignant. We must also note whether there is presence of any extraosseous soft tissue component, because extraosseous soft tissue component, if a significant amount of extraosseous soft tissue component is present, it always indicates that it is a malignant tumor. Now, why I'm telling significant, I'll discuss later. Enhancement, if you are seeing an MRI film, then you must also know the enhancement of the tumor, whether it is non-enhancing, or it is showing a homogeneous enhancement, or it is rim enhancing, or it is showing a heterogeneous enhancement. You should also note on an MRI what is the relation with the adjacent neurovascular structures, whether it is compressing or encasing any important blood vessel or nerves. And the last thing to report is the knee distance from the nearby joint, because that has an impact of it in case it's a malignant tumor and the surgeon is planning a amputation or a disarticulation of the bone. Now, I have discussed about how to differentiate between benign and malignant, and most of the books will also say like that only, that if it is a narrow zone of transition, classify it as benign, and if it is a wide zone of transition, classify it as malignant. However, in real practical life, you will find that there's a lot of overlap. There's a lot of overlap, and if you go by that, you can be wrong at many times. So here, I have decided this is a more practical approach for day-to-day practice and also for your examination point of view. So whenever you see a bone tumor, before jumping to conclusion that yes, okay, this is subarticular, this might be a GCT, or no, this is having a very sunburst appearance, okay, this is osteosarcoma, or I think there is some calcification, I think it is enchondroma. So before jumping to anything like that, first the thing is that first you try to classify the tumor into three broad categories. First is a benign. So when we call a tumor as benign, we call a tumor as benign when we are 100% sure that this tumor is benign. There is no doubt of any suspicion that it could be malignant. If you're trying classifying a tumor as benign, then even if you do not do any other investigation, even if you just leave the patient, keep it on a follow up maybe, or not even that, then that is totally okay. You will not do any workup for malignancy, at least in this case. So when you call it a benign, so if we are seeing an MRI and if we see that the lesion contains fat and or it is a completely cystic lesion, then we can definitely classify the tumor as benign. And remember that on X-ray we cannot see whether the lesion is containing fat or it is cystic. This can only be seen on an MRI. Another thing is that if you see a tumor in a less than 30 years old person and the tumor has a narrow zone of transition, or 99% chance is there that this tumor is benign. Narrow zone of transition in less than 30 years is always benign. Or if the tumor is showing a classic imaging features of a benign lesion, like we'll discuss, some of the tumors have very classic imaging features, then you can actually classify them into benign tumors. What is a malignant tumor? We classify a tumor as malignant when we are 100% sure that this tumor is malignant and it needs urgent workup. So, if a tumor is showing a break in the cortex without any history of trauma, then it is definitely malignant. And if the tumor is showing a significant amount of enhancing extra osseous component, then the tumor is definitely malignant. Now, why I'm telling significant? Because sometimes osteomyelitis also tends to produce some amount of extra osseous granulation tissue, which will enhance on contrast enhanced MRI, but the amount of granulation tissue will be very small, whereas the primary bone tumors such as osteosarcomas, Ewing sarcomas, the malignant ones, they produce large amount of extraosseous soft tissue mass. Okay, so if there is significant amounts of extraosseous soft tissue component, that tumor will be malignant. Rest most of the tumors on X-ray, actually in the practical world, we are going to classify them into indeterminate categories. And the criteria which puts a tumor into indeterminate categories are if a tumor is showing a wide zone of transition. Yes, wide zone of transition does mean that a tumor may be malignant, but we'll see later there are some benign tumors which produce a lot of bone marrow edema on MRI, and they on X-ray they can actually show a wide zone of transition. Or if you see a tumor which has a narrow zone of transition, but the patient is more than 40 years of age. So narrow zone of transition, I told, it indicates a benign tumor, but in more than 40 years of age, metastasis and myeloma are almost 10 times more common than a primary bone tumor. Not twice, not thrice, but 10 times more common statistically. And these metastasis and myeloma, they many times they have a narrow zone of transition on X-ray. We'll see examples of that. So you must classify them into indeterminate categories. Aggressive periosteal reaction. Yes, aggressive periosteal reaction is very favorable of a malignant tumor, but remember many times osteomyelitis will also show you a sunburst appearance of periosteal reaction, so it should be classified into indeterminate. And the cortex of the tumor should be intact unless there is a history of trauma. So if a trauma occurs, then a pathological fracture can occur across simple bone cysts also, and it can occur across a Ewing sarcoma also. But if the cortex is fractured without any trauma, then you must classify into malignant. But if the fracture has occurred and secondary to trauma, then we cannot, that is not a cortical break, that is a fracture. And the that is a fracture, so the cortex should be intact unless there is a history of trauma. Okay, if there is a history of trauma, there's a lesion, still it will go into indeterminate. And there should be no extra osseous component, no significant extraosseous component. Small amount of extraosseous component enhancing maybe osteomyelitis, but no significant extraosseous component. If significant extraosseous component is present, it will go into malignant. Now, using the simple approach, we'll see how easily we can see all the X-rays and also MRIs. So this is my case one. He's an 18-year-old male, and we can see the lesion. So we'll describe the lesion. The lesion is in the distal femur. It is in the epiphysis. It is a narrow zone of transition. It has got a sclerotic rim. There is no periosteal reaction. The cortex is intact, and there is no extraosseous soft tissue mass. So narrow zone of transition in less than 30 years old, we can classify this tumor into 100% benign tumor. And the differentials include two most common tumors which occur in the epiphysis. First is a chondroblastoma, and other is the giant cell tumor. And this tumor is actually a chondroblastoma. On an MRI, we can see this is the typical signal of cartilage on MRI. A cartilaginous tumors will appear very hyperintense on T2. They appear as if there are locules of T2 hyperintensity which have coalesced into each other. So this is appearance is very typical of cartilaginous tumors. And this is as a chondroblastoma. So what we learned in this case, we learned that which tumors occur in the epiphysis. So the epiphysis of the bone is generally a site for benign tumors, and the most common tumors which occur in the epiphysis are chondroblastoma and giant cell tumor. Chondroblastoma will generally occur into lesser age group, less than 30 years, less than 20 years, and giant cell tumor is an adult tumor. It occurs after 20 years of age, 20 to 30 to 40 years. That is the age group for giant cell tumor. And eosinophilic granulomas also sometimes in children less than 20 years it can occur. But there is one malignant tumor which is clear cell chondrosarcoma, which can also involve the epiphysis or the apophysis. So one malignant tumor is there, but most of the tumors will be benign in the epiphysis. And this clear cell chondrosarcoma, definitely it will be in a advanced age group. Now, this is case 2. Now, this is an expansile lesion in a 35-year-old female. It is involving the proximal tibia, and it is epimetaphyseal, that is, it involving both the metaphysis and the epiphysis. It is subarticular. The zone of transition appears to be narrow. The lesion is trabeculated, giving a soapable appearance. There is no periosteal reaction. The cortex is intact, and there is no extraosseous soft tissue component. So, narrow zone of transition in a young patient, not less than 30 years, but okay towards 35, towards 35, towards 30 almost. I think this tumor is a benign tumor, and this is a characteristic appearance of giant cell tumor. However, in differentials, when you may think that it may be chondroblastoma, but as I told, chondroblastoma less than 25 years of age, and this is adult patient, so giant cell tumor is more likely. And aneurysmal bone cyst occurs when the physis has not yet fused, but in this case the physis has fused. So this is not aneurysmal bone cyst, this is a giant cell tumor. And on MRI, again, you can see the subarticular tumor, which is the giant cell tumor. So remember, giant cell tumors are not entirely benign tumor. In fact, they are classified by many authors as quasi-malignant tumors because sometimes they show aggressive behavior. So in giant cell tumor, you may even get a cortical break. You may get small amount of soft tissue component extraosseous also because they are quasi-malignant tumor. But in this case, it's benign. Now, this is case 3. This is an X-ray from our own department in Patna. This was a 55-year-old patient, and she presented with some very lytic lesion in the distal end of ulna. The lesion showed it was involving both the epiphysis, metaphysis, and diaphysis, and the lesion showed stippled internal calcification, which is typical of a chondroid matrix. There was no periosteal reaction, but there was a break in the cortex, and there may we were unsure whether there is an extraosseous mass, but definitely there was a break in the cortex without any history of trauma. So this is a clear-cut malignant tumor, 100%, and this is none other than chondrosarcoma, very typical. Only cartilaginous tumor to be malignant is chondrosarcoma. And this, she is also carrying an MRI from outside. So this is her MRI, and we can see the typical T2 hyperintense cartilaginous matrix. And these dark signals are actually the chondroid calcifications. This is T1 weighted image, and this was a chondrosarcoma. Now, case 4, this is involving a calcaneum. So, 15-year-old patient, a very huge mass involving the posterior process of calcaneus, the wide zone of transition. It has an osteoid matrix inside. It is producing bone, and the cortex is broken, and there is a large extraosseous soft tissue component. So, 100% malignant. There's no doubt cortical break is also there, and extraosseous soft tissue component is there. So, impression malignant. And that what can be the differentials? So, osteoid producing tumors, there it is osteosarcoma. However, sometimes some metastasis, which are osteoblastic metastasis from prostate gland and all, they can also produce this like this. But this patient is very young, 15 years of age, and generally metastasis do not produce so large amount of extraosseous soft tissue. They are generally inside the bone only and well defined only. So this is osteosarcoma, not any metastasis. This we can see the MRI picture. There is some osteoid signal. This is osteosarcoma. Now, next case. Here, the patient is a 50 years old female, and she presented first with a fractured vertebra, and the vertebra has a vertebra plana appearance, and she also had pain in the humerus after trauma. So she had a trauma. This vertebra has a vertebra plana appearance, and this bone was fractured after trauma. But we can see that this is not a simple fracture. This is a pathological fracture because the fracture has occurred through a lesion. So, um, remember in spine, actually, the things that I taught, that zone of transition, matrix, and periosteal reaction, they are not very important in differentiating whether it is benign or malignant. Okay, some other components are useful. For example, in spine, if you see that the posterior column is also collapsed, then that indicates that it is a malignant tumor, vertebra plane appearance, because benign tumor will generally cause a wedge appearance. But here, as compared to other vertebrae, you can see that the posterior has also reduced in height, and the posterior is bulging also. So that these two indicate that it is a pathological collapse. And humerus is a wide zone of transition in a 50-year-old female. It is most likely a malignant tumor, but still we are not very sure. So a wide zone of transition, because this cortical break has not occurred due to the tumor. The cortical break has occurred due to the trauma, and there is no extraosseous soft tissue component. So better not to classify this tumor into malignant 100%. Yes, there's more chance that it is malignant. However, this tumor is still indeterminate, and the differentials could include either it could be a metastasis, or it could be a myeloma, or it could also be one of the benign tumor, which is brown tumor, which can also look like this only on X-ray, and it can also involve the vertebra sometimes. So this patient went to have an MRI, and on MRI we can see that the tumor body is totally infiltrated by the vertebral body is infiltrated by tumor, but the rest of the spine also shows this characteristic salt and pepper appearance. And this salt and pepper appearance is seen in multiple myeloma, and her CT scan also showed this raindrop skull. So this is a diagnosis of multiple myeloma. Now, whenever you see multiple bone tumors, always think of those tumors which have a tendency to occur in multiplicity, and those tumors include metastasis, myeloma, brown tumors, hemangioma, and lymphoproliferative tumors such as lymphomas. Now, this is a case of a man, and this is a 50-year-old man, and this shows typical ivory vertebra. So, this is known as ivory vertebra. When the vertebra is entirely sclerotic, the cortex is intact, there is no extraosseous soft tissue component. So, three things have been described in the literature which give rise to ivory vertebra. The first is osteoblastic metastasis, and if the patient is more than 40 years of age, it is 90% osteoblastic metastasis. Other is Paget's disease, and the third is lymphoma. So, how to differentiate? So, in book, it is described that in osteoblastic metastasis, the anterior concavity of vertebra will remain the same as that of other vertebra, whereas in Paget's diseases, vertebra will be expanded, and the anterior border will be very straight, like a picture frame vertebra. That will be expanded vertebra. And in lymphoproliferative neoplasm, there will be nodes anterior to this vertebra. So, this anterior margin will be even more scalloped due to pressure from the adjacent nodes. However, it is really difficult to recognize these subtle signs on X-ray, so it is better to get an MRI done. And on MRI, we can see that the tumor cells have infiltrated the vertebral body, and on axial section, we can actually see that there is a soft tissue component which is involving the vertebra. So this is not bone, this is some soft tissue, something projecting out, and this is typically a metastasis, because a metastasis. If it was Paget's disease, this wouldn't have seen the soft tissue. In fact, in Paget's disease, we see the cortical thickening. So, if it was Paget's disease, you see this is the very nice. We can see the end plate cortex here and there, which is appears of normal thickness. But in Paget's disease, the cortical thickness is increased. So we would have seen this cortex actually expanded, and this gives rise to the typical picture frame vertebra appearance. And if it was lymphoma, then definitely the entire spine or most of the spine would have been involved and not just one vertebra. Now, this is another case in 15-year-old male, and in the femur, we can see that there's a tumor in the femur. It is located in the diaphysis, and this tumor has a wide zone of transition. The matrix is lytic, but there is aggressive periosteal reaction, onion peel appearance, and the cortex is also broken, and there is an extraosseous soft tissue mass. So, broken cortex with extraosseous soft tissue mass, 100% malignant tumor, and the differential is only one. The tumor involving the diaphysis in 15 to 20 in 10 to 25-year age group is Ewing sarcoma. So in MRI, we can see the tumor. There's a large extraosseous soft tissue component. Okay, so whenever you see a large extraosseous soft tissue component, always think of any primary bone tumor. And now we learned that which all tumors can involve that diaphysis of a bone. So in order to remember the diaphyseal bone tumors, remember O female, it's a mnemonic which indicates osteoid osteoma, fibrous dysplasia, Ewing sarcoma, metastasis myeloma, adamantinoma, lymphoma, and eosinophilic granuloma. So these tumors can involve the diaphysis of a bone, more or less. But there can be other tumors also. I think brown tumors can also involve diaphysis, but in general, to remember this mnemonic will help. Now, in this case, there's a 35-year-old male, and he has got an inflated spine. So there is a ballooned up, one side of the spine is ballooned up in the lumbar vertebra, and the cortex is still intact. We can see, even though it is ballooned, the cortex is intact, and there is no extraosseous soft tissue component. This is inside the vertebra only, because we can see the intact cortex. But we don't know, we are very unsure what is this. It may be a chondrosarcoma also. Sometimes chondrosarcomas arise from the transverse process, so this is an indeterminate lesion. And the differentials of this lesion include those tumors which involve the spine, for example aneurysmal bone cyst, a giant cell tumor, osteoblastoma. These are the tumors that can involve the spine, but they can also be chondrosarcoma. And metastasis generally, they do not give rise to this blown up appearance, but yes, metastasis from the kidney and the metastasis from the thyroid, they can show blowout metastasis, which sometimes maybe is this large. So we decided to do an MRI, and in MRI we see an expansile lesion and involving the body as well as the arch of the vertebra, and the entire tumor consists of blood fluid levels. So this is an aneurysmal bone cyst. So we discussed which tumors affect the spines. In benign tumors, giant cell tumor will generally affect the body of the vertebra, whereas aneurysmal bone cyst and osteoblastomas will generally affect the neural arch of the vertebra, and osteoid osteoma will involve the pedicle. Sometimes malignant tumors will also involve the spine, such as metastasis myeloma, and malignant primary tumors such as chondrosarcomas can arise from the transverse process from the pedicle. And in a child, if you see clear cut malignant tumor in the spine, then that could be Ewing sarcoma. Now, not just ABC or aneurysmal bone cyst, whereas other tumors can also show blood fluid levels, such as telangiectatic osteosarcoma, and some other benign tumors, such as giant cell tumors, chondroblastoma, fibrous dysplasia. They have a tendency to show secondary ABC changes within them. So, other tumors, if they are showing blood fluid levels, the blood fluid level will be limited to one portion of the tumor, because the rest of the portion will be a solid. But in ABC, the entire tumor actually consists of spaces containing blood fluid levels. So this is an ABC. Now, this is another case. This is a 20-year-old male in the proximal femur metaphysis. We see a lytic tumor with some, I don't know, maybe some nidus inside, and there is a wide zone of transition, and there is so much sclerosis outside. So we do not know till where this sclerosis is ending. Therefore, this tumor has a wide zone of transition. There is no clear-cut difference between this bone and this bone. So this tumor has a wide zone of transition, but the cortex is intact, and there's no extraosseous soft tissue. There is some sort of smooth periosteal reaction also. So this, but still, even though there's wide zone of transition, even though there is some periostitis, I will classify this tumor as benign, because this is the classic imaging finding of a tumor, benign tumor, of classic imaging finding of a benign tumor, and that tumor is osteoid osteoma. So if you see a classic, remember the first algorithm that I showed, a classic imaging findings of a benign tumor is there, then you must classify it as benign. And this is osteoid osteoma. There is a nidus inside which is calcified, and there is sclerosis inside. But this can another differential for this can be Brody's abscess. If suppose there's a lytic lesion and there is some surrounding sclerosis, you can confirm this on either on CT or MRI. In MRI, we can see that there is a nidus and there is surrounding so much soft tissue edema. So this tumor is itself is very small. This is so small, just less than 1 centimeter, but it's having a large amount of bone marrow edema. And sometimes can have so much bone marrow edema that it is spreading outside also. It can have some surrounding soft tissue edema also. It is so edematic. So there, what are those tumors in which you will see out of proportion bone marrow edema on MRI? Okay, there are certain tumors which are out of proportion bone marrow edema. First is osteoid osteoma, as in this case. The second is osteomyelitis. So how to differentiate between osteoid osteoma and a Brody's abscess? So osteoid osteoma, typically the nidus is less than 1 centimeter, whereas in osteomyelitis, the nidus is more than 2 centimeters mostly. And if this size criteria is not very helpful for you, you can do a contrast enhanced MRI. And in osteoid osteoma, the nidus enhances, whereas in the osteomyelitis, the Brody's abscess, the nidus actually is the necrotic core, consisting of pus, and it will not enhance. It can either show no enhancement or a rim enhancement, but never central enhancement. Whereas in osteoid osteoma shows central nidal enhancement. Other tumors which can show out of proportion bone marrow edema includes eosinophilic granulomas, chondroblastomas, and sometimes osteoblastomas. Now, this is a tumor in 25-year-old in the distal tibia, well-defined, narrow zone of transition, lytic lesion, no periosteal reaction, no cortical break, and no extraosseous soft tissue component. This is clear-cut benign tumor, because a narrow zone of transition in less than 30 years old is always benign. So clear-cut benign tumor, and the differentials of this could either be a simple bone cyst or a chondromyxoid fibroma. Now, how to differentiate between a simple bone cyst and a chondromyxoid fibroma? So do an MRI and we can see on MRI this is a solid tumor. It is not a cystic tumor. It is not a cystic tumor. It is a totally solid tumor. So it is a chondromixed fibroma and not a simple bone cyst. Now we learn the differential of a lesion which occur in the metaphysis, and those tumor lesions are simple bone cyst, aneurysmal bone cyst, chondromyxoid fibroma, and osteosarcoma. So the simple bone cyst and aneurysmal bone cyst, when the bone actually grows and there is ossification of the physis, they can actually move some deeper inside and they can actually come to lie inside the diaphysis. So, but they always arise in the metaphysis. Okay. Now, this is a case from our own department. This is a 35-year-old male, and he presented with a large extraosseous tumor, and entire sacrum was also permeated, and this was a very large tumor. So, extraosseous soft tissue mass, such a big one. So, it is clear-cut malignant tumor, and the differentials include chondrosarcoma or the tumor which is known for involving the sacrum, which is a chordoma, or it could be metastasis. But metastasis unlikely to produce such large amount of extraosseous soft tissue component. So metastasis is lower on the list, most probably chondrosarcoma because it has this striated enhancement which is typical of chondrosarcoma, or it could be a chordoma also. So what are the so this sacrum, as we can see, and it was finally a chondrosarcoma. I followed up this patient, and this patient was diagnosed with a myxoid chondrosarcoma. Now, whenever we see a tumor in a non-tubular bone, that means a flat bone, such as this one, a sacrum. Sacrum, though it is a vertebra, it can be considered as a flat bone. It is not like other vertebra, lumbar vertebra. It is more or less flat in shape. Then other flat bone examples are skull bones, sternum, ribs, pelvic bones, iliac blade, sacrum, pubic rami. Then small bones such as patella, such as carpal bones, tarsal bones, small bones. So whenever we see a tumor in these areas, we must think of those tumors which have a tendency to involve the non-tubular bones. So if you see a benign tumor in a non-tubular bone, and if it is a child, then you should think of eosinophilic granulomas, aneurysmal bone cysts, and sometimes chondroblastomas also. Whereas if you see a benign tumor in a flat bone in an adult, you should think of either a giant cell tumor or a brown tumor. If you see a malignant tumor, cortical break, extraosseous soft tissue component, that means malignant, in a child, then you should think involving a flat bone such as a rib maybe or a sternum. Then you must think of or pelvic bone. Then you must think of Ewing sarcoma, and sometimes it may be osteosarcoma if it has a osteoid matrix. And if you see such a malignant tumor in an adult, then we should think of chondrosarcoma. But sometimes metastasis and myeloma can also involve them. And if the tumor is in the sacrum, like in this case, or in the clivus of the occiput, then it can be a chordoma also in an adult. Now, this case I've included to make you understand that how something as common as an osteochondroma can sometimes confuse us. So these are two different tumors. Yes, one of this tumor is benign and other one is malignant. So this one is actually an osteochondroma, and it is an exophytic tumor called as exostosis, and it is a benign tumor. And this one is actually a malignant tumor. Now we'll see, we have the MRI of both these tumors. So how to differentiate? So osteochondroma, the medullary cavity of the parent bone actually goes inside this osteochondroma. It communicates with the osteochondroma, and this is a cartilage cap. So this is osteochondroma. Whereas that another tumor which I showed you was a parosteal osteosarcoma. This is a parosteal osteosarcoma, and in this case, the medullary cavity of the tumor will not communicate with the surrounding bone, surrounding tumor. So that is a parosteal osteosarcoma. So you have to differentiate them. And now this is a small lytic lesion, but there is stippled calcification inside it, narrow zone of transition, and this patient is 35 years, okay, not less than 30 years, but 35 years of age. No periosteal erection cortex is intact, and there is no extraosseous soft tissue component. This is a classical imaging appearance of an enchondroma, therefore it is classified as benign. However, one entity that you can confuse with enchondroma is a bone island. You can think that it is a anostosis or bone island. How to differentiate it? So if this was a bone island, it would have been dark on both T1 and T2, completely sclerotic. However, we can see that is a typical cartilaginous matrix. So this is an enchondroma. This is another very similar tumor in a 40-year-old male, narrow zone of transition showing internal calcifications. But remember that narrow zone of transition in a 40-year-old, we will not classify it as into benign. We will classify it into indeterminate, because more after 40 years of age, we know that there is very high chance of metastasis in myeloma. So we will not classify it as benign, we'll classify it as indeterminate. And the differential, it could be that it could be a chondroma, in chondroma it could be an osteoblastic metastasis also, or it could be a bone infarct also. So we do an MRI, and an MRI we can see that this lesion actually contains some serpiginous lines inside, and there is some T1 hyperintensity which gets suppressed on fat set sequences. So this is basically fat. The tumor contains fat and serpiginous lines. So any tumor which contains fat within itself on MRI, 99% it will be benign, and this is a typical bone infarct. And what are the tumors which can show fat within them on MRI? So if the tumor is like this, it is a bone infarct. It can show fat within it. If the tumor is completely fatty, then it is can be a lipoma. If the tumor is partly fatty, partly solid, then it can be a liposclerosing mesofibrous tumor. Or if a tumor is hemangioma, like we see hemangioma is also T1 hyperintense on T1 weighted images. So that is also fat containing tumor. Now, this is a case from our own department. 55-year-old female. She presented with pain in femur, and in her proximal femur location, and there was a well-defined lytic lesion, a sclerotic border, cortex intact, no periosteal reaction, no extraossseous soft tissue component. But remember, narrow zones of transition in a more than 50 years old, classify it as indeterminate, not as benign. Okay, it will go into indeterminate category. So actually I followed up this patient, and that was diagnosed to be a myeloma. So this was a myeloma in this patient. Her calcium levels was raised, her kidney was also damaged. So this is a deposit of myeloma. So the differentials could be that this lesion could be either be a metastasis, it could be a myeloma, and it could either also be a benign tumor. Sometimes benign tumors may be seen in more than 40 years of age, though less, but yes, it could be a simple bone cyst, it could be a fibrous dysplasia, although it is lacking that typical ground glassing appearance of fibrous dysplasia, but it may be. And remember that metastasis and myeloma, they can look very much benign. Even on MRI, they will look very well defined, no cortical break, no extraossseous counting, they were well demarcated. So, but whenever you see any patient more than 40 years of age, always include metastasis and myeloma in your differential diagnosis and classify the tumor as indeterminate. Now, this was another case. This patient came to us for ultrasound. She was carrying an X-ray in which there was this subarticular tumor in the proximal tibia, typical trabeculations, eccentric, subbubble appearance, and it was reported outside as giant cell tumor of proximal tibia. And literally, I have no reason to say that this is not a giant cell tumor. This looks entirely like a giant cell tumor, and the patient's but calcium levels was raised. So, as radiologists, we do not get the information. We do not have any clinical data that the patient's calcium level is raised. So later on, it was found that her calcium level was raised. She came for a thyroid screening, and we actually found a parathyroid adenoma near the inferior pole of thyroid. And then we advised the patient to get an MRI done. There were multiple lesions in many bones, and this is not giant cell tumor. These were actually brown tumors. And later we got an X-ray. The X-ray repeated to cover a larger area, and we could really see that there are multiple tumors. So this is a brown tumor. This is a brown tumor. This is not a giant cell tumor. So see how overlaps can occur. So whenever you see multiple tumors, think of the lesions which show present as multiple tumors, which include metastasis, myeloma, brown tumors, hemangiomas, lymphomas, because GCTs will never present as multiple tumors. So these are brown tumors. Now, this another case of two patients to show. So this looks very aggressive lesion, lytic lesion, and ill-defined wide zone of transition. Some periostitis is also going on. Some periosteal reaction is also there, perhaps smooth, although smooth. And this one too looks very aggressive. This has got a speculated periosteal reaction almost. But these two, in fact, they are osteomyelitis. So osteomyelitis is one thing which can mimic anything. It can mimic a benign bone tumor, it can mimic a malignant bone tumor. So it is a great mimicker, it is a great masquerader. How to catch it? You can actually catch it up on MRI, because MRI will show out of proportion bone marrow edema and out of proportion facial and soft tissue edema in these lesions. Generally, neoplasms, they do not cause so much adjacent soft tissue edema. the edema will be proportional to the amount of soft tissue. Okay, there's a large soft tissue, of course it will lead to some edema, but here you see there is no that such big soft tissue mass, but the edema is so much. And here also we can see this T1 weighted image, we can see so much edema is there. And also another way to catch it is that osteomyelitis often tends to involve the adjacent joint, whereas a neoplasm never, almost never crosses the adjacent joint. So these are my references. Thank you.